So hello friends, today we will be talking about a new topic that is from the respiratory medicine, tuberculosis. So this video will be basically helpful to the basic science as well as the clinical students and as well as those who are preparing the PG entrance examination. So let's start. I will be highlighting some of the MCQ points also in this question. So will be totally helpful for the MCQ question also. So let's start. So the first question is that the main causative agent for the tuberculosis is mycobacterium tuberculosis. Everyone knew that. And the mode of infection is basically the aerosolized droplet nuclei from the infected patient. So see, this is, let us suppose this is an infected patient. This person is already having MTV. He has already having mycobacterium tuberculosis. Now from his, when he sneezes out, then from his, the respiratory aerosolized droplets come in the air, and that air is actually inhaled by a normal individual who is near to him, and whenever this aerosolized droplets come in contact with the healthy person, it will eventually go into the two places. Either it will go and land into the tonsils of this person. So either this bacteria or this aerosolized droplet will land into the tonsil of that person. So the one point where the bacteria can land into this normal person, let's suppose this is a normal person, but now this normal person is exposed by the affected person. So the bacteria can lodge into tonsil, and another point, the bacteria can lodge into the area of the lungs. So basically the primary area where the bacteria will lodge is basically the lower part of upper lobe and upper part of middle lobe. So in this area, especially in this area where this is the lower part of the upper lobe and upper part of the middle lobe. So basically in this area, the bacteria can get lodged in the lungs primarily, and in the mouth, in the oral cavity, it will ultimately lodge in the tonsil. So in some patient, the bacteria can lodge into the tonsil. In some patient, the bacteria can lodge into the given area in the lungs, and in some patient, it can lodge in the both places. Now everyone should know one point, that is actually the ghon focus. GHON ghon. Sorry, GHON ghon and focus. So how this ghon focus will be formed? So the first thing I want to tell you that the ghon focus will always form at that area where the bacteria will land at first. So you see in this picture that the bacteria will be landing either in the tonsil or in this part of the lung. So always the formation of ghon focus will be either at the tonsil or at this part of the lung. So the MCQ question, what is the site of the ghon focus? So the site of the ghon focus will be either the tonsil, or the site of the ghon focus will be the upper part of lower lobe and lower part of the upper lobe and upper part of the middle lobe. So there are two sides of the ghon focus. One side is the tonsil and lower part of upper lobe and upper part of the middle lobe. So this question can be asked, and many students will actually take in apex, but in the apex the ghon focus will not be formed. Usually whenever at the first time when the bacteria attacks you or attacks any person, then the bacteria will form the ghon focus at either in this part or in the tonsil. It will not attack the apex. Now let's suppose there are two types of person, and one person is a healthy individual. Let's suppose one person is a healthy individual. He is immunocompetent, and let's suppose there is another type of person who is actually let's suppose he is a child, or he is actually elder patient whose immune condition is somehow poor, whose immune condition is somehow poor. And let's suppose that in each patient, in each patient actually they were exposed to the mycobacterium tuberculosis. So let's suppose a healthy individual who is exposed to the mycobacterium tuberculosis. So now let us suppose that in this patient the bacteria gets lodged into the at the first time the bacteria gets lodged into the lower part of the upper lobe and upper part of the middle lobe. So here the bacteria lands, and whenever the bacteria will land here, the first thing that will come to counter attack this bacteria will be actually the macrophages present in the alveoli. So the first thing that will come here to attack these bacteria, let's suppose these are the bacteria, so they will be actually alveolar macrophages, and ultimately this alveolar macrophages want to attack this bacteria, but this bacteria will do certain endosomal manipulation, and they will actually do certain more things that will prevent them from phagocytosis, and that will actually prevent them from killing. So ultimately the bacteria will not actually get killed by the alveolar macrophages. Then the alveolar macrophages think that I am not able to kill this bacteria, I should modify me. So macrophages basically modifies, and they change into the epithelioid cell. And now when they change into the epithelioid cells, they start to secrete the certain kind of so let us suppose this is the epithelioid cells. So these are basically the barrel shaped cells, and now the epithelioid cells start to release certain kinds of enzymes, and some of the epithelioid cells fuse together and also form the Langhans giant cell. And ultimately now the enzymes released by the Langhans giant cell, the macrophages, and some more lymphocytes that have come there. So there are some lymphocytes also. So ultimately there will be the high amount of enzyme secretion in the area where the bacteria has lost, and due to this the bacteria along with the tissues present over there get necrosed. So ultimately there will be the caseous necrosis. Caseous necrosis, and ultimately a cavity will be formed, and this cavity is known as the ghon focus. The cavity will be formed, and this cavity is known as ghon focus. So in this way, a ghon focus was formed in the healthy individual. Now, so once the ghon focus is formed, so ultimately the area where the bacteria was landed was actually necrosed, and in that area a cavity was formed, and in that area the cavity now the bacteria is somehow killed, and somehow some bacteria still remain there. And now the bacteria start to travel along the nearest lymphatic channel. Let us suppose that here is the ghon focus, and let us suppose that we have our lymphatic channel. Here we have our lymphatic channel, and let us suppose this is the nearest lymph node of the hilar region. So this is a lymph node, this is a lymph vessel, and when the cavity is formed in this area, most of the bacteria will killed, but some bacteria again trickle down into the nearest lymphatic channel, and now the inflammation involved the lymphatic channel or lymphatic vessel. So this condition is known as lymphangitis. That is an inflammatory reaction involving the lymph vessel is known as lymphangitis. And when this bacteria reaches to the lymph node, now this bacteria causes the inflammatory changes in the lymph node. So this is known as lymphadenopathy. And now the involvement of the ghon. So this was the ghon focus. And when the ghon focus from the ghon focus, the bacteria came and involved the lymph vessel and involved the lymph node. This overall, all the thing is known as ghon complex. So what is ghon complex? So when the ghon focus involves the lymph vessel and the lymph node, then in that case we will call it as a ghon complex. So in this way the ghon complex is formed. And now, as we know that this person is a healthy person, this person is an immunocompetent person. Up to this time, the antibodies and the different cell-mediated immunity has came into their role, and due to which there will be the fibrosis around so simply what they will do now, from the lymph node the bacteria can spread all over the body, but the immunocompetent host inflammatory response wants that the bacteria should not go anywhere from here. So in this person, his or her immune system are not letting the bacteria to now go out from this place. So they will ultimately cause the fibrosis around this complex. And later on there will be the calcification around this fibrosis part. So initially, to actually seal out the bacteria, to not let go out anywhere from this place, there will be fibrosis around the ghon complex, and there will be calcification around the ghon complex, and this the thick layer that is formed around this lymph node and the lymph vessels, they will actually ultimately seal the bacteria in this area, and this actually what are the changes that occur in the ghon complex is known as now Ranke's complex. So I think you know what is Ranke's complex. So Ranke's complex is actually conversion of the ghon complex into the calcified and fibrous wall, and now the bacteria will not go anywhere from this wall, and the bacteria will remain latent in this wall. So in the Ranke's complex, bacteria will remain latent, and somehow this bacteria can remain viable or can remain live in this Ranke's complex for almost 5 years. And after the 5 years, the bacteria will die from this Ranke's complex, and the person will not have any kind of symptom. He will be totally fine, and there will be no any problem. So in this way, we can see that in the normal healthy individual, when the TB bacteria comes, then also they will not develop any kind of tuberculosis, especially because the reason is that, so they will form the Ranke's complex, and the bacteria will remain latent, and they will not develop any kind of disease or symptom. So simply we can say that a normal healthy individual will not develop TB basically in the first stage, when the bacteria came and formed the ghon complex and the Ranke complex. But the things are not similar in case of the children, elderly, or who are immunocompromised person. So see what will occur in this person, that in this person there will be the formation of the ghon focus. I have already said you how it is formed. So there will be formation of ghon focus, there will be the lymphadenopathy, there will be the lymphangitis. It means there will be the formation of ghon complex also. So ghon focus and ghon complex will be formed, but the Ranke's complex will not be formed. So there will be no Ranke's complex, as we know that the Ranke's complex, for the formation of Ranke complex, there will be requirement of the good immune status. But this person is a children, his immune is not developed, or this person is elderly, the immune is not giving so much response to the any illness, or the person is immunocompromised. So there will be no Ranke's complex formation, and now the bacteria will actually travel from the from the lymph node to the various body parts, or they will simply disseminate. And now they will disseminate, and they will cause actually the miliary TB. I will tell you the mechanism how the dissemination take place, when the miliary TB will be formed, or they will cause the systemic TB. Either there can be the TB of the meninges, or there can be TB of the liver, TB of the kidney. So any organ can be affected. So simply I said that in the children or in the elder, in the immunocompromised person, if you will not treat the disease, then they will go in the dissemination phase, and they can do affect the both lungs. If there is one lung affected, then both lung can be affected, or there can be the dissemination of the disease in the whole body organs. Either there will be bone, or there can be the TB from the CNS or the liver or the kidney, or there can be the TB of the skin. So any part of the body can be affected. So we saw that the primary TB start to progress in this patient. The primary TB start to progress in this patient. So basically in children and elder and only immunocompromised person, there will be the primary progressive pulmonary TB. Primary progressive pulmonary TB. Why it is called primary progressive? As the primary TB progresses to the progresses and cause the disease. Now it causes the disease, and the disease was evident in the body. So this primary TB itself progressed. That's why it is known as primary progressive pulmonary TB. So you saw that in the children or the elder or the immunocompromised, there will be no Ranke complex, and directly the primary TB will progress on and cause the different variety of symptom, or the disease will be so much evident in this condition, and that will be known as the primary progressive pulmonary TB. As the primary TB progresses, that's why it is known as primary progressive pulmonary TB. So now you will ask me that how a healthy individual will develop a TB, as we saw that many patients who are healthy but also they develop TB. But in previous I said you that that the primary focus where the actually for primary in the primary region, there was the formation of the Ranke's complex. There was a formation of the Ranke's complex, and the bacteria will not actually now disseminate anywhere, and the person will remain asymptomatic till many years. But yes, when this immunocompetent person becomes immunocompromised due to any reason, either let us suppose this immunocompetent individual have developed now HIV, or is under any therapy which is actually compromising his immunity. Let's suppose he is taking corticosteroid, or let's suppose that he is on the any renal transplant or any other renal transplant or any other thing, or in any condition, if his immune system is somehow lowered, in that cases there will be the reactivation of the bacteria from this Ranke's complex. So from the Ranke's complex there will be reactivation of bacteria, and the bacteria from the lymph node again will come to its initial bone focus, and now it will travel to the apex of the lung. And apex. So now the apex will be involved. So such type of tuberculosis which occur after the formation of the primary TB. So see, this tuberculosis is actually evident after the primary TB was formed, but in the primary TB the person did not develop any kind of symptom, as there was the Ranke complex, there was a good immune status. But once the immune condition is lowered or immune status is lowered, then there will be reactivation of bacteria from the Ranke complex, and the bacteria will now go into a special site, that is apex of the lung. So this TB is known as secondary TB. So remember this point, this TB is known as secondary tuberculosis. Okay, so in the secondary TB, basically we should know one thing, that this TB is due to the reactivation of bacteria from latency. The bacteria was silently sitting in your body while was not doing anything, but when your immune status was lowered, then the bacteria start to again reactivate and from its latent condition, and that's why it is also known as reactivational TB. So the names are secondary TB, reactivational TB. So these are the different names of this TB. So usually in the adult, when the adult person develops the tuberculosis, basically it is secondary TB, or it is reactivational TB, or we can say it is a post-primary TB, post-primary pulmonary TB. And in this, when the secondary TB occurs, the site where now the we can say the ghon focus will be developed, or the necrosis or the cavity will be formed, that is apex of the lung. So in the secondary TB, the main site where the cavity will be formed is apex of the lung. So now you saw that in this way the apex of the lung is involved. So when the question will come that what is the most common site of the infection in the secondary TB, you will answer the apex of the lung. But in the primary TB, you will answer the upper part of the lower lobe and the lower part of the upper lobe and the upper part of the middle lobe, and or the tonsil. So basically summarizing what we have studied up to now. So in adult, in the immunocompetent person, the first primary TB there will be primary tuberculosis, but there will be formation of the Ranke complex. The person will remain asymptomatic, and whenever the immune complex asymptomatic for either the week or month or several years, and whenever there will be the weak immune system, the disease will get reactivated, and the secondary activation or the secondary attack of the bacteria will be at the apex, and there will be secondary tuberculosis. And when there will be secondary tuberculosis, the bacteria will now the bacteria will disseminate, and what will happen on the dissemination, I will tell you now. See, if the patient is of old age or children, there will be primary TB, there will be no Ranke's complex formation, there will be dissemination of the bacteria, and there will be extra pulmonary manifestation. So see, here I have told you that there was dissemination. So after dissemination, there will be similar thing, like there will be extra pulmonary manifestation like the CNS TB, liver TB, bone TB, abdominal TB. And in the children, directly the primary TB progresses, so we will call it as a primary progressive pulmonary TB. But in the adult, there will be no progression of the primary TB. Actually, there will be reactivation, and the secondary TB will be evident as a disease. That is why in adult, usually the main cause of the disease is secondary TB. But in the children or the elders, there will be the main cause of the disease is primary progressive pulmonary TB. So up to now, I just said you that in adult, usually the secondary TB occurs. But in some cases, there can be the primary progressive pulmonary TB in adults also. So let's suppose there is an adult and who has not previously sensitized to the mycobacterium tuberculosis. So there is no previous Ranke's complex present in his body, and the first time the bacteria or the mycobacterium tuberculosis attacked, and for the first time the ghon focus was formed. But suppose somehow the person is adult, but somehow his immune is weak. Let's suppose that he is around 30 years and now he is having the diabetes mellitus, or he is having any kind of the chronic disease, and due to his immune status is relatively weak, and now the ghon focus will directly progress, and ultimately there will be primary progressive pulmonary TB. There will be no Ranke complex formation, and ultimately the disease will go into the dissemination. So simply either in the primary progressive or in the secondary TB, there will be the dissemination of the tuberculosis. So let's see what happen when the disease disseminate, and what condition will occur. Let's see this. So now let's suppose this is a lungs, and we have the airway present over here, and let us suppose if the person is the child, he will have the ghon focus at this area, and if the person is adult, he will have the the cavity in the area of the apex. So somehow in the adult or in the children or in the adult, there is somehow the ghon focus in the different areas. And now the ghon focus will, in children the ghon focus will progress, and adult also, if the TB is secondary, it will progress. So the cavity will just increase its size, So let's suppose the cavity is increasing its size, and a time will come that it will actually combine with the nearby airway. So let us suppose that this is a nearby airway, and let us suppose here was a cavity. Initial cavity was here, and now the cavity start to progress. Let's suppose the cavity start to progress, and ultimately as the cavity start to progress, it will actually involve the nearby I mean the airway. When the nearby airway will be formed, there will be necrosis of the nearby airway also. So the wall of the nearby airway will be dissolved, and now there is the cavity inside this, and the whole the debris will be actually go in this airway, and the debris will be coughed out. So in this time there will be what? There will be cough, and this cough is basically the necrotic debris or the mucus production over the airway is present in the cough, and there will be the smaller vessels that will be covering the bronchioles. So this is the bronchiole. So this is the bronchial artery, or we can say the bronchial veins. So whenever the cavity are progressing, they will also actually cause the damage to the bronchial artery or bronchial veins. And when the bronchial artery or bronchial vein will get damaged, there will be the bleeding. And so ultimately bronchial artery vocal vein when get damaged as the cavity is progressing. So this cavity is progressing, and when the cavity will progress, there will be damage of bronchial artery or bronchial veins, and when this bronchial artery bronchial vein will damage, then the blood will also come inside the debris. So there will be so whatever the sputum that, so let's suppose that here will be the debris, and this debris is now containing the blood, and when this type of debris along with the mucus will coughed out, then there will be the sputum mixed with the blood. So there will be the sputum mixed with the blood. This is known as hemoptysis. So there will be sputum mixed with blood, and this time the bacteria present over the cavity will also be present in the sputum. So this time the sputum also contain the bacteria. As now the sputum contain the bacteria, so at this time the person will be infective, so he can infect the normal other individuals. So at this time the person will be infective. So at this stage person will be infective. So you can see that actually the main thing is that in the adults usually the cavity will be larger. Whenever the secondary TB occurs in the adult, the cavity will be larger, and the cavity when involved the bronchi or the bronchioles, they will cause the damage to the bronchial vessels, and the mucus along with the debris present over there, they are coughed out in the cough, and when they are coughed out, the sputum contain the blood and the bacteria, and in this time the person is actually infective. So this situation occur in the adults. So whenever a adult patient came to you with a complaint of sputum with a mixed blood, and the classical history of tuberculosis, like he is also telling that I am having the fever, I am having the night sweat, I am having the weight loss, and I am having the cough with bloody sputum, then you should actually suspect, there will be highly suspicion of the tuberculosis. And in that case, you should understand that now the cavity has enlarged so much, that is why the cough is actually containing the blood. So whenever a patient with the cough plus with the blood will come, then you should suspect that this patient is at a higher stage of tuberculosis. As if the cavity was small, it was not connected to bronchioles, But if the cavity is larger, then only it will connect it to the bronchioles or nearby airway. That is why if it is connected to the nearby airway, it means the cavity is somehow larger, and the cavity will be larger only in the adults. The cavity will be very smaller in case of the children. Why the cavity will be? The cavity will actually progress or become large in adults and will be smaller in children. And if the cavity will be smaller in the children, it is very good. I mean that it is very obvious that if the cavity is smaller, it cannot connect to the nearby airways. If the cavity is small, it will not connect to the nearby airways, and that's why the children will not develop mostly the hemoptysis. And if you will examine his or her in children's sputum, though they are having the tuberculosis, the sputum smear, that is AFB, if you will do sputum smear acid fast bacilli staining, then that will come negative. Though the person is having TB, though the children is having TB, the AFB sputum smear will become negative. Why? As the cavity will be formed in the whatever the cavity will be formed in the children will be smaller. So in the children the cavity will be smaller, but in the adults the cavity will be larger. And if the cavity will be larger, then only it will connect to the nearby airway, and then only there will be sputum mixed with the blood, or sputum contains the bacteria. So are you getting my point? So yes, this was the main thing. Now the second thing is that why the cavity is larger in the adult and why it is small in the children. So see, simply you have to know that whenever the bacteria attacks, the main problem of the necrosis is not due to the bacteria. The main problem why there will be actually ghon focus formation here, that is less due to bacteria and more due to our immune response. What happens in the children? The immune response is somehow weak. That is why only the bacteria will do damage, but our immune system will not favor the damage. That is why in the children the disease will progress and the cavity will not get enlarged, and the immune system is not attacking, only the bacteria is attacking. Yes, immune system will attack, but in very less amount, and that is why there will not be a spread of or extension of the focus, and that is why there will be less chance of the hemoptysis, or there will be less chance of the bacteria coming in the sputum in the children. But in the adults, in the adults the immune response is somehow better than the children, so that is why there will be more extensive the damage of the tissues of the lungs, and that is why the cavity will get progress and will connected to the nearby airway, and there will be manifestation of hemoptysis or the presence of the bacteria in the sputum. That is why in the children there is no need, or there is no any necessary to do a sputum smear, as it will be most of the time it will come negative. So though the bacteria will be present in the children, but the sputum smear will be negative. So directly you should not go for sputum smear, that is AFB in children, as it is already understood that will come negative. But in the adult, yes, in adult the test will come positive. That is why you should go for the sputum smear first. So this was a concept that you should know. So let's do some workup. Let us suppose if any person is coming and he is having the history or the classical sign and symptom of tuberculosis, but the sputum AFB is positive. If the sputum AFB is positive, it indicates that the person is having the large cavitatory lesion in the lungs, and that is why there will be simply you should think that there is more bacteria. If the sputum smear is negative, it doesn't exclude that the person is not having TB. It simply says that the person may have the small cavity, and at this time the airway is not connected to the lesion, and that is why there will be less number of bacteria. So this type of condition will be seen in children, and this type of condition will be seen in adults. So let's talk about something about secondary tuberculosis. So I said you that in the secondary tuberculosis, usually the from the initial focus, the bacteria will travel and come to the apex, and in the apex, let's suppose this is the level of the clavicle. So this is a clavicle. So the bacteria can lodge above the clavicle or just below the clavicle in the apex. So let's suppose this is the area of the apex. So the bacteria can lodge above the clavicle or below the clavicle. If the bacteria lodges above the clavicle, and here if the focus will be formed or the lesion is formed, then this lesion is known as Pool's lesion. So these are the MCQ question. So Pool's lesion is basically the supraclavicular region. Supraclavicular region. And if the lesion is formed below the clavicle, it is known as Asman focus. Asman focus. And it is a infraclavicular region. Similarly, if the bacteria disseminate, then let's suppose that the bacteria after dissemination attack the CNS. Then in the CNS, the focus that will be formed is known as ridge focus. Let's suppose the bacteria attack the liver. So in the liver, the bacteria will be forming the Simon focus. Simply the name are given of the different focus, but the lesion will be same, that the main histopathology in the lesion will be same in the all areas. And if again in the lung, if the bacteria affects, but again the secondary lesion in the lungs, if remain again inactive in the lung itself, then such lesion is known as Simon lesion. Simon focus we can say. So there is a difference, Simon and Simon. The Simon focus is in the liver, and these are the active focus where the bacteria is present. But in the lung, where the bacteria is not present, has done lesion but bacteria died. So such lesion in the lungs are known as Simon focus. So in the secondary TB or the primary progressive TB, if the dissemination take place, then how it is taking place and how it is affecting different organs, let's study. So let us suppose this is a cavity, and now from this cavity the dissemination will take place. So if this cavity progresses and involves the pulmonary artery, as we know that the lungs have the two blood supply, one from the pulmonary circulation and another from the bronchial circulation. So let us suppose that the pulmonary circulation is actually involved by the bacteria. So as we know that the pulmonary arteries, when they get drained, then they will actually, the two pulmonary artery both lungs are connected. So if bacteria is from the one side, let's suppose the bacteria is on the right side of the lung, then if it involve pulmonary artery, it can again go into the left side of the lung. So let's suppose it's a left lung, so it can go in the left lung as well. So if the bacteria or the cavity involves the pulmonary artery, then there will be the seedling of the bacteria in the different part of the left lung also, and there is already involved in the right lung also, in the dissemination in the right lung itself. So in this case, there can be the miliary pattern will be seen. So there will be miliary tuberculosis. So miliary tuberculosis will be seen if there will be involvement of the pulmonary artery. So in this way, if there will be involvement of pulmonary artery, so there will be miliary tuberculosis. So now if the cavity is involving the let's suppose not pulmonary artery, let's suppose it is involving either bronchial artery or bronchial veins. So let's suppose these are involving the bronchial artery or bronchial veins. So in this way, in this condition, we know that the bronchial artery or the bronchial veins will ultimately drain into the heart, and heart is a pumping organ. So ultimately, whatever the bacteria will go into the bronchial artery or bronchial vein will go into the heart, and from heart it will disseminate all over the body. So it can go in the CNS, it can go in the liver, it can go in the bone, it can go in the different lymph nodes, and etc. So in this way, the bacteria can reaches all part of the body if it involves the bronchial artery or bronchial vein. But in case if the bacteria involve the bacteria, if the lesion is involving the bronchus or airway, then the lesion will, and then the bacteria along with the sputum get coughed out, and if the sputum of the bacteria will get coughed out, then in that case, if the cough is swallowed, so again the bacteria along with the sputum will go into the GI tract, and in the GI tract it will basically affect the ileum, especially at the ileocecal junction. So this is also again a question, that at which point in the GI tract especially the tuberculosis bacteria affect, then that is answer is ileocecal junction, and they will ultimately cause the necrosis at that area, and ultimately there will be the stricture formation in the ileocecal junction. So there will be ileocecal stricture formation, or we can say simply that there will be the abdominal tuberculosis in this case. So now let me tell you one more thing, that so that your concept regarding the pediatric tuberculosis will not get so much confused. So let me tell few more things. See, actually when in the pediatric patient, or in the less than 5 years patient, what happened, that yes, it is true that the cavity will be small, but it is also true that the lung is also small, and as the lung is small, the everything is so much compacted in this pediatric patient. I mean that there will be so much smaller airways present all over the lungs, and there will be very less space between the alveolar tissues and the airways, That is why though the cavity will be small, there can be the chance that there can be the communication of any airway to the cavity. It's not that there will be yes, there will be less chance, but yes, there can be the communication of the cavity with the airways, and basically the smaller airways, not the larger airways. So from the smaller airways, the bacteria can go, and the cavity can involve the smaller airways. So in the pediatric population, yes, the cavity will be smaller, but there will be so much smaller airways, so can involve smaller airways, and if it involves smaller airways, then yes, again at this time there can be the presence of the bacteria in the the pediatric patient, or in the pediatric sputum. So we can say in that if there will be involvement of the smaller airways, there can be presence of sputum, the bacteria in sputum of pediatric patient. So it is not that yes, you should always prefer for the gene export test. Always prefer for the diagnosis in the pediatric patient, you should prefer the gene export test. And I said you that there can be presence of the bacteria, but yes, the sensitivity that the bacteria will be present in the sputum is very less. So there will be less chance of getting bacteria in sputum. I said you why, as the cavity is small, so it is very less chance that the cavity can involve the smaller airways. But yes, if they will involve, then there can be the presence of the bacteria in the sputum, and if they will not involve, then there will be less chance of getting bacteria in the sputum. And that is why the sputum EFB can be done. Yes, the sputum EFB can be done if the gene export test is not available. So sputum EFB can be done, but you should remember that it will, most of the time it will come negative, though we will do if the gene export test is not available. And especially if the bacteria come also, if the bacteria, let's suppose if the bacteria come in sputum, it will be in very less amount. So in the sputum, bacteria will be very less amount. And usually the children, what they will do, they will not actually throw out the sputum, they will actually swallow all over the sputum. And if they will swallow the sputum, the bacteria will also remain in the stomach. The bacteria will remain in the stomach. And that is why for the diagnosis, if the children is very small and if he or she cannot actually produce sputum or actually give you a sputum sample, in that case you can take the gastric lavage. So what we will do, you will actually put a nasogastric tube in his from the nose into his stomach, and you will actually aspirate some of the fluid from the stomach. And now this fluid is sent for the gene expert test, or can be sent for the AFB staining. But yes, especially this fluid is sent for the gene expert test. This gene expert test is also known as CBNAAT. So CBNAAT means it is a cartridge based test. So CB means cartridge based. So test basically for the tuberculosis. And so basically in the pediatric population, if you will always prefer the gene expert test, and if the children is able to give you the sputum sample, then that is good. If the children is not able to give you the sputum sample, you can take the gastric lavage. And but yes, the sensitivity of the sputum test is very less, as the number of bacteria in the sputum will be very less, and there can be the no bacteria in the sputum also. So these are the things that you have to know in the pediatric point of view.